So the first paper is by Dr. Josmin Raphel, Visual Impairment Assessment Efficacy with ERG.
Good morning, everyone. My paper is on the topic Visual Impairment Assessment Efficacy with Electroretinogram in Children on Vigabatrin and a Descriptive Study. So, Vigabatrin is an anti-epileptic drug mainly indicated in cases of refractory seizures in children, and a major ocular adverse effect is retinal toxicity, which is manifested as visual field loss and is estimated to have a prevalence of about 30 to 40%. But for most children on vigabatrin, this cannot be assessed due to their young age and neurodevelopmental delay. So we need an objective test for detection of the retinal toxicity. So vigabatrin actually acts at the presynaptic terminal by inhibiting the enzyme GABA transaminase and thereby increasing the concentration of this inhibitory neurotransmitter and producing an anti-epileptic effect. So our study is to analyze the efficacy of assessing retinal toxicity of vigabatrin by using electroretinogram in a group of children with epileptic disorders. So we did this study as a retrospective study at a tertiary eye care institute from the time period 2016 to 23, and we collected data from electronic medical records which included detailed clinical history, functional vision assessment, ocular alignment and movement, cycloplegic refraction, dilated fundus examination, and ERG recordings at baseline visits and every 3 monthly follow-up visits. So the thing is, normal vision or visual field assessment is not possible in cases of these children. So we performed a functional vision assessment. But this is not a reliable test in detecting toxicity because it depends upon the general status and cooperation of the patient. So electroretinogram was taken at the baseline visit and follow-up visit under oral sedation with the syrup pidichloril. And following the ISCV guideline, we recorded the ERGs in retiport scan. In Gansfield illumination and detailed thread electrodes were used. We recorded visual evoked potentials in cases only in indicated cases. So coming to the results, out of the total 20 subjects, which included 11 boys and 9 girls, the mean age of the study population was 5.4 years, and the majority of the study population was below the age of 3 years. Mean duration of therapy in our study population was 41 months, which was ranging from about 1 month to 9 years. Only 2 study subjects had a longer duration of therapy of more than 5 years. The major indication of the drug in our study population was West syndrome or infantile spasm, followed by hypoxic ischemic encephalopathy. And in the study group of infantile spasm, the etiology was mainly idiopathic, followed by tuberous sclerosis. So this is how the frequency distribution of functional vision assessment at the baseline visit went, and about 70% of the children had poor functional vision at the time of presentation, indicating a need for an objective assessment. And moreover, 2 children who developed vigabatrin toxicity actually showed improvement in functional vision assessment that can be probably due to better seizure control, establishing that it is an unreliable indicator for assessing vigabatrin toxicity. So this is a table which shows the absolute values of B wave and oscillatory potentials in the 7 patients who developed vigabatrin toxicity. So this is a serial ERG of a single patient who had vigabatrin toxicity. ERG waveforms are shown from the baseline at the top trace and the follow-up 3, 6 and 12 months of visit, which shows a gross reduction in the B wave amplitude. So this is a percentage reduction of the ERG amplitude from the baseline through the follow-up visits in all the 7 patients who developed vigabatrin retinal toxicity. This is a linear plot which shows reduction in the absolute value of the oscillatory potentials in the patients who developed toxicity. VEPs were recorded only in cases of suspected optic nerve dysfunction or optic nerve pallor, and we got 7 case subjects who had optic nerve pallor clinically, but the abnormal waveforms were present only in 3 of them. But there was no significant correlation between VEP and retinal toxicity. So coming to the discussion, the prevalence of vigabatrin-induced retinal toxicity in our study group was 35%, which is less than that of Westall et al. That was 21%, which is the largest cohort of children with infantile spasms investigated for vigabatrin-induced retinal toxicity, and it is compared to Magyar et al., which is a systematic review. Our study showed a percentage reduction of ranging from 55 to 83% in B wave amplitude, which was 37 to 52% in Westall et al. Reduction in the amplitude of this light-adapted 30 Hz flicker cone electroretinogram is associated with vigabatrin attributed field loss, so it provides an assessment of retinal damage. Oscillatory potential reduction with the vigabatrin treatment was also observed in our study. So there have been studies which shows male predilection in vigabatrin-induced retinal toxicity, but this was not observed in our study. Coming to the conclusion, vigabatrin has been known to cause retinal toxicity in long-term usage. Hence, assessment in pre-verbal population with a reliable investigative modality is of utmost importance. Our analysis indicates that ERG is an effective tool for monitoring vigabatrin-induced retinal damage in pre-verbal children. These are my references. Thank you.
So I have two comments. Very nice study, good thought. What's the mechanism of VGB causing a retinal toxicity? Which layer or where does it affect?
The exact mechanism has not been till date has been discovered, but they say that it is at the photoreceptor level and the bipolar cell level, the damage causing due to increased level of this inhibitory neurotransmitter probably.
So what's the limitation of using full field ERG as a marker for any of these toxicity? Can you think of a limitation of ERG as a tool?
So one, it is it's not available in every center.
No. So the limitation would be ERG generally is a summative response,
Okay.
and it tells you if larger area of the retina is affected.
Yes, sir.
If the toxicity is limited to macula, it may not reflect in full field ERG. Then you require a multifocal ERG
Yes, sir.
to reflect. Number one. Number two, please remember, though VP is described as an optic nerve function test, but actually the origin of the VEP is from the macula.
Yes.
So anything which can affect macula in a larger scale would be reflected in VEP as well,
Yes.
right? But a very nice study.
What about cerebral visual impairment? Would that affect these tests?
These ERGs, ma'am, actually we are not taking the absolute value of the B wave amplitude, but we are comparing it with the baseline of that patient itself. So we are looking for a significant reduction in the B wave amplitude rather than the absolute value. There will be an reduction when we compare it with the normal population. Actually, there is reduction in B wave amplitude because these babies are mostly having neurodevelopmental delay. So the absolute value is not what we consider, but the reduction. We have the follow-up visits.
Further going to your study, what happened to the patients though had toxicity?
So the thing is, we have not taken any fields to establish that the results we got with the ERG is comparable to what we expect to have. So the thing is, giving Vigabat. So we advise the pediatric neurologist to stop the drug, but it is actually on their hand also because the baby may be only having controlled infantile spasm with this single drug. So it is sometimes they stop, but sometimes they continue at a lower dosages and they review again for repeat ERGs.